called Chlamydiaceae. And the family Chlamydiaceae are obligate intracellular parasites. So that means they are incapable of replication when they are outside of a host cell. And the concept that I've seen that sometimes students find a little bit challenging is what is the difference between a bacterium like this, that's an obligate intracellular parasite that cannot reproduce without a host, and a virus, which we tell you, oh, they're not living, they're not cells, but they also depend on a host. So the difference is bacteria, even if they are obligate intracellular parasites, they make their own ATP and they make their own proteins. Like they have their own ribosomes. They make their own proteins. They can make their own energy. Viruses can't do that. So that's why even if they are obligate intracellular parasitic bacteria, they're still living. Whereas viruses, we consider them not to be. They are very small. They can pass through those 0.45 micron filters. And because of that, the symptoms of the disease caused by this organism were thought to be caused by viruses instead, because usually only viruses are that small. They are organized, oh, thanks. And we have parafilm, so you can wrap your plate. I'm like, how does she find me? I don't know if we don't have like Find My iPhone or anything like that. So they're organized like a gram-negative bacterium. That means that and we'll talk just a minute about the two phases, but in the replicative phase, they have two membranes, right, and a thin layer of peptidoglycan. And they have a sort of unique developmental cycle. When I say sort of unique, we don't talk about a ton of bacteria that replicate like this, so it's unique in terms of one of the few bacteria we talk about in class like this. They have two stages, basically. We call them elementary bodies, abbreviated EB, or reticulate bodies, abbreviated RB. The EB, the elementary bodies, are metabolically inactive. They're like dormant, but they are infectious. That is the stage of the life cycle that is passed from person to person or from cell to cell. So it's inactive, it can't replicate because it's not inside the host cell, but it is the one that can attach to and be internalized by the next cell. When the elementary body has been internalized by a cell, it reorganizes itself into the reticulate body. The reticulate body is the metabolically active form. So it's the one that replicates and does metabolism inside of the host cell, but it's non-infectious. So if a reticulate body comes into contact with a new host cell, it can't cause an infection. So you have to have both in order to have the life cycle. The thing about the elementary bodies, because they are kind of dormant like that, they are resistant to harsh environmental conditions. So they're resistant to drying, they're resistant to some of the disinfectants, and sometimes they may or may not have peptidoglycan, depending on how they've reorganized themselves. So if they don't have peptidoglycan, that also makes them resistant to cell wall inhibiting drugs. Right? So these elementary bodies are tricky to get rid of, basically, is what we're trying to say. Within the species that causes chlamydia itself, but within the other species as well, there are different, what we call serovars. They cause slightly different manifestations of disease depending on which major outer membrane protein they have. And then there's a protein called outer membrane protein 2 that helps to stabilize those elementary bodies. We're only going to talk about one of the species in this family. There are others that cause human disease that are mentioned in your textbook, but this one is the major one. So like I said, they are parasites. They depend on the host. They can make their own ATP, but they usually don't. So they tend to be pretty dependent on the host. But Again, compared to viruses, they make their own proteins. They have their own ribosomes. Viruses don't, and we'll talk about viruses in a little bit. So what happens when the bacteria get into the host cell, you have the elementary body. This one is infectious. Inactive, infectious. Binds to a host cell and gets internalized. Within the host cell, and what they're trying to show here is that the elementary body, which was orange, rearranges or reorganizes inside the phagosome into a reticulate body, the metabolically active form. Then it will divide by binary fission. It's a bacterium. They all kind of replicate in a similar way. And some of the new reticulate bodies will reorganize back into elementary bodies so that they can spread and cause further infection. But they're still all contained within like the phagosome. So you get this large, they call it an inclusion, and you can sometimes see these under a microscope. You can see in the host cell the inclusion vacuole or phagosome that contains the mixture of reticulate and elementary bodies. Eventually, it gets to be very large and is extruded from the host cell through reverse endocytosis or through exocytosis, and that releases all of the elementary bodies. There might be some reticulate bodies still left in there, but remember, those are non-infectious. They can't cause an infection in the next cell. Only all of these reticulate body or elementary bodies will do that. So elementary bodies will go cause more infection. And attachment to extrusion usually takes about 72 hours. So 3 days. Okay. The species that we're going to talk about within this family is Chlamydia trachomatis, and this causes a couple of different diseases. Most commonly, we think of chlamydia. That's the one that we've probably all heard of. In terms of chlamydia, we're talking about a urogenital infection. And the serovars that cause the urogenital infection are listed here. So you can have a more mild urogenital tract disease, and that's what we classically think of when we think of chlamydia as an STI, that a patient has a urogenital infection. Because remember, in males, the urinary tract and genital tract are the same. In females, we're talking mostly a genital tract infection. Now, there are a handful of serovars that cause a much more serious form of disease called lymphogranuloma venereum. And unfortunately, we'll see pictures of what that looks like in just a minute, but it's a way more severe disease. The other serovars at the top are more commonly associated with trachoma, which is an eye infection. So Chlamydia trachomatis can also cause eye infections. The reason that it can cause infection in so many different types of tissues is because the elementary bodies can pretty much bind to mucous membranes. Urethra, cervix, endometrium, fallopian tubes, anal rectal area, respiratory tract, conjunctiva. They can bind to your mucous membranes. The serovars that cause the LGV, the lymphogranuloma venereum, are a little bit more invasive because they can replicate inside of phagocytes, like macrophages or monocytes. So that gets them into the lymph nodes, basically. So the symptoms are caused by the destruction of host cells and also the production of pro-inflammatory cytokines because of host cell infection. And because those LGV serovars get into the mononuclear phagocytes and get transported to lymph nodes, you end up with lesions in the lymph nodes as well. And again, these pictures are never really clear because of the lighting, so hopefully you see it better on your screen. But with those LGV serovars in the inguinal, like the groin area lymph nodes, you can have really significant swelling, and that's what's shown here. Those lesions can become necrotic, right? Because you are having tissue destruction caused by, again, the pro-inflammatory cytokines, but also this idea that you're getting this mass production of elementary bodies inside of the host cell. So those cells eventually die because they've been completely taken over by these little chlamydia cells. With the non-LGV serovars, so the ones that cause trachoma and the ones that cause that classic urogenital infection, we do tend to see a pretty significant inflammatory response. And unfortunately, what we also see is that infection or previous infection does not provide immunity. So with a lot of infections, if you get the infection once or you get vaccinated, you are protected from a further infection. But in this case, this is one of the infections we'll talk about where a secondary infection actually leads to a more enhanced immune response. So it's worse when you get it again. So the immune system, instead of like fighting off the infection, kind of overreacts and can cause more tissue damage. And depending on the site of infection, and depending on the severity of infection, which serovar we're talking about, etc., we see chlamydia associated with everything from vision loss. So if it gets in the eye, if it's trachoma in the eye, sterility, and permanent sexual dysfunction because of all of the inflammation and tissue damage. When a mother is infected with chlamydia, if the child is delivered vaginally and exposed to the bacterium during childbirth, anywhere from 10 to 20% of those newborns exposed to the bacterium can develop pneumonia. Remember, it binds to the respiratory tract. It's a mucous membrane. So it can cause pneumonia. It is the most common bacterial STI and the most common reportable infection in the United States. Over 1.8 million reported infections in 2019. It is estimated that that is an underestimate of the true number of cases. The CDC estimates approximately 3 million infections per year. That's just under 1% of the population of the US every year. But the main serovars tend to be those associated with the more standard STI. We tend to see the urogenital serovars. We don't usually see LGV in the US, and we don't often see trachoma in the US. In other parts of the world, all bets are off. Whatever serovar is whatever serovar. But in the US, we tend to see just the classic urogenital STI. The more invasive, the more severe serovars that cause LGV are more common in Africa, Asia, and South America. And we tend to have the male patients have symptoms more commonly than the female patients. And this can be good and bad if you're the female patient. Good that you're not experiencing symptoms because it's unpleasant to have symptoms of an infection, but bad because you don't actually know that you have this bacteria most likely moving up your reproductive tract, and that undiagnosed infection, untreated infection progressing up the reproductive tract can eventually lead to infection and scarring of especially the fallopian tubes and cause permanent sterility. So kind of blessing and a curse when you have a sexually transmitted infection that doesn't cause symptoms. So, I like these maps because they kind of show that county by county breakdown. You can see where we have the highest levels of infection, highest rates of infection. So Stanislaus County up here, we're at what's considered like the second highest rate of infection. Don't go to Fresno; they're the highest. They're at the highest levels. And then I don't know why this headline it just like it made me laugh. I just laughed. A reason to stay home on a Saturday night. More than 100 million Americans have a sexually transmitted infection, researchers have found. So yeah, the bacterial ones, I told you, they're not like all that high. But if you start adding things like human papillomavirus, so HPV, herpes infections, herpes simplex infections, cytomegalovirus, like some of the viral STIs as well, that's when the numbers really shoot up. So now we're doing math. More than 100 million Americans, that's real close to about 1/3 of the US population. And I would be willing to make a bet that like the majority of children under the age of 18 probably don't have sexually transmitted infections. So when you look at the patient population, it's probably higher than 30% in adults. And weirdly enough, the elderly really have high rates of sexually transmitted infections when they get back on the dating scene, because it was different back then. Okay, so trachoma, we don't see commonly in the US. It's a chronic disease that causes eye infections. And what we tend to see first is what we call follicular conjunctivitis. Basically, the follicles of your eyelids, right? That's where we're having infection. So conjunctivitis is the common name for conjunctivitis is pink eye. So it's that infection of kind of the eyelid area. But if left untreated, it causes scarring. And that, like, I hate eyes so much. So of course, like, I have to talk about eyes. I have like a scratch on my eye. Like, it all comes together in one day. What happens is the chronic infection leads to tissue damage, leads to scarring, and it eventually leads the eyelids to invert. And so if you picture your eyelids, how your eyelashes point out, what happens is they start to point back in, and the eyelashes scrape the cornea and cause scratches on the cornea. And that is as painful as it sounds. Because I can tell you, having a scratch on the cornea is quite painful. My eyelids didn't do it, my eyelashes didn't do it, but it hurts. We can also have patients who develop more of an acute infection instead of the chronic trachoma. They will have a discharge out of the eye. If you've ever had pink eye, you probably know what it's like to have that eye infection and to have that infectious discharge, the mucopurulent discharge. But again, if it's treated relatively quickly, you're okay. But if left untreated, you can get that corneal scarring. And so what I want you to notice here is that those serovars D through K, those are the ones that are most common in the US, and we typically see them associated as urogenital infections. Those can also cause eye infections, generally more like the adult inclusion conjunctivitis. We can also have neonatal conjunctivitis, and this would again be if a child is born to a mother who has chlamydia and is delivered vaginally, the bacterium can get in the eye, and you have what you would imagine with conjunctivitis. You have swelling of the eyelid, you have discharge. It can spread and cause pneumonia in untreated or topically treated infants. So if you only treat the eye instead of give like a systemic antibiotic. The infection would be acquired during childbirth, and 25% of children born to mothers with active infections will develop the conjunctivitis. So some will develop pneumonia, some will develop conjunctivitis. Untreated conjunctivitis can also, or not completely treated conjunctivitis, can lead to neonatal pneumonia. So with trachoma, this is basically what you get. You get the inversion, the bottom eyelid has inverted, right? And it's scratched up, and this person is now blind. It's a permanent blindness that we see in some parts of the world. And this is what the discharge can look like from the cervix. So the infant pneumonia would show up 2 to 3 weeks after birth. They'll have rhinitis, like a runny nose, and they can have I guess it's a distinctive cough. I've actually never heard a newborn cough with pneumonia caused by chlamydia, but they say it's like a staccato cough. So if you've done music classes, like a rapid, like quick cough. Again, urogenital infections, most women are asymptomatic, which makes them an important reservoir for spread. If you don't know you have an infection, how are you going to get treated? And the main early symptom is going to be discharge, a mucopurulent discharge. So this is a case of Chlamydia trachomatis pneumonia in newborns. So 2 infant girls with Chlamydia trachomatis pneumonia. The first infant was born by vaginal delivery at 39 weeks, the second by cesarean. Because of fetal distress at 40 weeks, the infants were in good condition until fever and rapid breathing developed at 3 and 13 days respectively. So 3 days in the vaginal delivery, 13 days in the cesarean. Chest x-ray showed infiltrates in the whole lungs. Cultures of blood, urine, throat, feces, cerebrospinal fluid were all negative, but antigen tests for Chlamydia trachomatis were positive from conjunctival and nasopharyngeal swabs. So just having a C-section doesn't completely eliminate the risk. Remember, these microorganisms can travel up the urogenital tract into, in women, the uterus, the fallopian tubes, right? So what's stopping an infant from getting infected there? And really probably what happened, the amniotic sac is very protective. It was probably during delivery, if the adult patient had the bacterium that had moved up into the uterus, when the amniotic sac is ruptured, that can allow exchange. So it's more rare to see any infection passed from the mother to the child with a cesarean delivery, but it's not a 0% risk. So the cases illustrate the presentation of pneumonia in infants infected with Chlamydia trachomatis at or near birth, although the characteristic staccato cough was not described. Again, not described just means that they didn't write it down. It doesn't, or they didn't publish it in their paper. It doesn't mean that it didn't happen. It just means they didn't publish it. The other thing to think about is, so you have infants, neonates, right, with pneumonia. They clearly have infection because their lungs are full of infiltrates, but culture is negative. So why would culture for chlamydia be negative? They're full of it. So those of you going into medicine, how do you culture an obligate intracellular bacterium? You have to use eukaryotic cell culture. It's the same thing. How do you culture a virus? Using eukaryotic cell culture. So unless they were trying to culture with eukaryotic cells, this is not going to, chlamydia won't grow on a plate, is basically what I'm trying to say. It's not going to grow on a plate. So it can sometimes be missed because you're looking for other things when you're culturing from the lungs. So it's just important for you to be cognizant of that. Okay. I showed you that about 80% of female patients will be asymptomatic. About 75% of male patients will be symptomatic. So males are going to be the one more likely to experience symptoms and therefore more likely to seek treatment than the female patient, because the female patient may not experience symptoms. In males, it can lead to what they call Reiter syndrome. So it can progress up the urogenital tract and cause inflammation of the urethra. It can spread through the body and cause conjunctivitis, so the eye symptoms. It can cause arthritis, polyarthritis in multiple joints, and it can cause lesions on mucocutaneous surfaces, so kind of the exposed mucous membranes. With chlamydia, co-infections with gonorrhea are pretty common. Generally, what you see when you have patients who are presenting with symptoms of sexually transmitted infections, they're often engaging in unprotected sexual activity. Maybe with multiple partners, don't know. But co-infections are pretty common. And one of the challenges is if a patient turns up, like, it burns when I pee and I have discharge, it's really easy to culture gonorrhea. So a lot of the time, you'll culture the gonorrhea, you'll tell the patient, well, you have gonorrhea. You'll treat the gonorrhea, and the patient will be like, I still have pain and discharge. What is wrong? And then it turns out, oh, you actually also have chlamydia. So now we need to treat the chlamydia. So that is not an uncommon phenomenon. So if you have a patient who shows up with a sexually transmitted infection, or at least symptoms of one, make sure you kind of look at all the possibilities. So this is a case of Reiter syndrome and then pelvic inflammatory disease. So those are going to be, we're going to have two different patients really. You have the male patient who presented to University Hospital with, this is what always kills me when I read these cases, and these are published in like reputable journals. So this happens, a patient with a 3-year history of like painful urination issues. He's 30 years old, like you're an adult man, like letting it be awful when you pee for 3 years. 3-year duration, penile inflammation, joint swelling, and fever. You would think any one of, especially the first two, would get you to the hospital quicker, but I guess not. Skin lesions and nail changes were also noted. So he is having issues basically over his whole body. High levels of chlamydia antibodies were present, but antigen tests and nucleic acid amplification tests of the urethral exudates and conjunctiva were negative for Chlamydia trachomatis. However, they did make the diagnosis of Reiter syndrome and began treatment with ofloxacin. Complete remission of the skin lesions and urethral symptoms was achieved. The patient's wife was also admitted to the hospital with a history of 2 years of lower abdominal pain, vaginal bleeding, and discharge. You should not have vaginal bleeding or discharge or pain for 2 years. Okay, but it happens. And of course, she was also positive for Chlamydia trachomatis infection, which had progressed to pelvic inflammatory disease. So it had moved out of just the vaginal area and caused issues up higher in the pelvis. Confirmed by positive cervical and urethral antigen tests. Vaginal smear was also positive for Trichomonas vaginalis. So she had a co-infection with a sexually transmitted eukaryotic parasite. So we'll talk about Trichomonas later. So these patients illustrate two complications of Chlamydia trachomatis urogenital infections, Reiter syndrome in the male and pelvic inflammatory disease in the female. So, I don't know why they didn't seek treatment. Maybe they were embarrassed. It says it's a European journal, so I don't want to say that they didn't have health insurance because, other countries actually provide health care for people. If this was the US, I would be like, yeah, maybe they didn't have health insurance, but whatever, they didn't show up. So with the LGV, the lymphogranuloma venereum, they'll develop small painless lesions about 1 to 4 weeks after infection, but it's the secondary stage. So after that, that's when you get the inflammation and the swelling, including the formation of buboes that can rupture. And so we talk about buboes when we talk about plague as like the plague-infected lymph nodes, but bubo is really just an infected lymph node. So you get bubo formation with the LGV serovars of Chlamydia trachomatis as well. And so those can rupture. Women who have the LGV serovars, or female patients that have the LGV serovars, can also experience proctitis, inflammation of the anus and rectum. Male patients can experience that as well. But, if you think of the anatomy, in female patients, the vagina is closer to the anorectal area, so it's more likely that it could spread there, but in males it can happen too. Oops. An untreated infection, you kind of roll the dice here. It could resolve, or it could lead to chronic ulceration with ulcers, fistulas, and elephantiasis. So I would always seek treatment. But again, we're talking about areas that maybe don't have, in parts of Africa, parts of Asia, parts of South America, that don't have access to the same medical care that we do. So it's far more likely that these could go untreated. Okay, so we can diagnose based on microscopy, most commonly microscopy, serology, or nucleic acids. You can do culture, but only if you're proficient with eukaryotic cell culture. So you can't just culture them on a plate. There's no kind of like growth media, but you can culture them with eukaryotic host cells. Most clinical labs probably wouldn't do this. Things like nucleic acid tests are the best because they're the most sensitive. For antibiotics, doxycycline is generally the antibiotic of choice for adults. For children or for pregnant women, we tend to lean towards erythromycin. Prevention is difficult, but mostly safe sex practices, prompt treatment of symptomatic patients and their partners. So especially if you have a monogamous couple where one is experiencing symptoms of chlamydia and the other is not, the other one probably has it too. And it's very likely that the first partner who's experiencing the symptoms brought it in from a previous relationship. So that happens where symptoms can take a long time to develop. So if you had one relationship, you've entered another relationship, right, then it can spread that way. Okay. Questions about chlamydia? Yes.
Earlier you said that it's like resistant to disinfectants and stuff. So when would that would it be in like healthcare situations or?
I mean, that's more like, you're not, they were, if you sit on a toilet seat, like you can get chlamydia, like not really, but yeah. But I guess that's the, excuse you could use. Oh, I must have sat on a toilet seat. Any other questions about chlamydia? Okay. So we are going to leave the bacteria and move on to viruses. So viruses are filterable agents. They are small and pass through filters is basically what that means. They are obligate intracellular parasites. They cannot make energy or proteins independent of a host cell. So they cannot make their own ATP, they cannot make their own proteins. They must use host cell machinery to do so. Now, viruses are going to be the only group of organisms that can have an RNA-based genome. Every other organism has a DNA-based genome, but some viruses use RNA as their genetic material. They do not use DNA. Some viruses use DNA. We do not know of any viruses that use both. So if a virus is an RNA virus, it is always an RNA virus. If it's a DNA virus, it's always a DNA virus. Very broadly, we can separate viruses by morphology into naked or not naked. And if a virus is naked, it's always naked. If it's not naked, it's always not naked. And naked means it doesn't have an envelope surrounding it. It's simply an exposed protein coat. That's naked. Not naked, the term for it is enveloped. It has a membrane that surrounds it. So if the virus has a membrane, it always has to have a membrane to be infectious. If it doesn't have a membrane, it never has a membrane. So we don't say that viruses divide. We say that viruses are assembled. So they can replicate by assembly, not by division. So the consequences of that. Viruses aren't living. We generally think that things that are living are a full cell and are capable of making their own proteins at bare minimum. Viruses have to be infectious to endure in nature. If they're not causing an infection, they're not able to replicate. If they can't replicate, eventually they die. As much as something not living can die, it dies. The virus has to be able to use the host cell to produce the components necessary for replication, for assembly. If a virus wants to do something fancy, it has to bring its own genetic material to make the fancy thing. And we'll talk about viruses that do fancy things. Viral components must be able to self-assemble. So what is a virus? The most basic viral organism, the most basic viral structure is one type of genetic material plus structural proteins. And they may or may not have other stuff on the inside, like their special stuff they bring with them. But basically, genetic material surrounded by proteins, that is called a nucleocapsid, or a naked virus. So they have genetic material, they've surrounded it with structural proteins. That is a naked virus, the most simple type of virus. There are some viruses that have taken their nucleocapsid and evolved to have a membrane that surrounds it. Those are the enveloped viruses. And as we talk about the different viruses, we'll talk about the consequences of having one type or another. So we classify viruses. We can't put them on the tree of life. They don't have ribosomal RNA. That's how we make the tree of life. The tree of life is made on your ribosomal RNA sequence. They don't have a ribosomal RNA. They don't get to be on the tree of life. But we can classify them based on their structure, by their nucleic acids. So a lot of the old names are because of their shape or because of their size. So P coronaviruses, they look under the microscope, the electron microscope, a lot like coronaviruses. They're just smaller. So they're P coronaviruses instead of coronaviruses. Their biochemical characteristics, the disease they cause, lots of encephalitis and hepatitis viruses. How they're transmitted, arboviruses are arthropod-borne viruses spread by insects. We can classify them based on host cell or host range. We have animal viruses, we have plant viruses, we have bacterial viruses. And the tissue tropism. Adenoviruses of the upper respiratory tract, enteroviruses, GI tract. So they get their names based on a lot of different things. But these are some of the major viral groups, and we'll talk about some, but not all of them. So you have your DNA viruses, the envelope, like look at dichotomous key. It's been a minute since you've seen one of these, huh? You're gonna make one on Wednesday, have fun. Not for viruses, for bacteria. But DNA viruses can be enveloped or naked. Some of the common enveloped viruses are the pox viruses, like smallpox and mpox. The herpes viruses, like herpes simplex and chickenpox. And hepadnaviruses, like hepatitis B. You have naked DNA viruses, polyoma viruses, which we're not really going to talk about, but papillomaviruses, like HPV. Adenoviruses that cause the cold, and parvoviruses, which cause parvo in animals, but can cause human disease too. And then you have the RNA viruses, and the RNA classification is a little bit more complex because the RNA can be either single-stranded or double-stranded. And if it's single-stranded, it can be the sense strand of RNA that looks a lot like an mRNA, or it can be the antisense strand. So they call it positive or negative stranded RNA. So you have positive strand RNA viruses that can be naked or enveloped. So here you have naked, like the P coronaviruses, like polio is in there. Enveloped toga viruses, flaviviruses, coronaviruses. I don't think I need to give you an example of a coronavirus. I think you probably can figure out one of those on your own. Negative sense strand RNA viruses, mostly the ones that cause human disease, are enveloped. Rhabdoviruses like rabies, filoviruses, Ebola, orthomyxoviruses like the flu, paramyxovirus like measles, Bunya and arenaviruses, which are arthropod-borne usually. You have a double-stranded RNA virus. They have a double capsid, which is really cool. And again, I'll tell you what that does. RIO stands for respiratory, enteric, and orphan viruses. So it's kind of like we didn't really know what they do, but they all are kind of related. So let's put them all together. So we'll talk about some of those too. And then this one, I told you you can't have RNA and DNA at the same time, and I truly mean that. But what this indicates here is the genetic material of the virus is an RNA molecule. In this case, it's a positive sense strand, so single-stranded RNA virus. But in order to replicate, it makes DNA as an intermediate. So it turns RNA into DNA, and then it turns it back into RNA and makes proteins. And the family that's really common that does this is the retroviruses like HIV. So this is kind of how viruses are organized and how they replicate. And so the smallest organization for a virus, the smallest like infectious particle, is called a virion. So a virion is a single infectious viral particle. For a naked virus, again, it's going to be the genetic material with the proteins. For an enveloped virus, it's going to be the genetic material and the proteins surrounded by the envelope. So whatever the virus has to have, like, that's it. That's the virion. So if it's a naked virus, this is the virion. If it's an enveloped virus, this is the virion. So we'll stop there. Before you leave, please grab a plate, a swab or two if you want, and at least one piece of parafilm to wrap up your plate after you've done your swab. Okay? And I will see you all on Wednesday with your plates.